So good morning, good afternoon, good evening to everyone. My name is Mutarika Pruksapong, Program Management Officer at the Global Education and Training Institute of the UN Office for Disaster Risk Reduction here in Incheon, Republic of Korea. Very warm welcome all of you to the training on the whole of society approach to creating healthy, resilient, and sustainable cities, harnessing South-South cooperation for post-COVID era. Let me also remind you at the very beginning here that we have interpretation channel available. While the training will be primarily in English, we have the interpretation service available for Arabic, Chinese, French, Portuguese, Russian, and Spanish. You can simply click the globe icon at the bottom of your screen and select the language of your preference. We also have turned on the live captioning service. Is the automated live captioning service, of which you can also turn on and off at the bottom of your screen. This training is organized by 4 of the UN agencies: the UN Office for Disaster Risk Reduction, the United Nations Office for South-South Cooperation, the World Health Organization, and the Pan American Health Organization. The training consists of 4 sessions, and you have attended already the first one last week. This week is the second training sessions and will last 90 minutes. All the sessions will be starting at the same time. There is a little bit of the course requirements I also want to remind you of. For the participants to receive the certificate of completion, you will need to attend at least 3 out of 4 live sessions and must complete a course evaluation survey at the end of the course, as well as passing an end of the course exam, which is actually a multiple choices questions. And you must score above 80% in order to achieve the certificate of completion. Your attendance will automatically be recorded as you sign on to the learning platform as you are doing now. So please make sure that you use your own credentials to sign on into the learning platform. Otherwise, your attendance may not be captured. I'm also very pleased to share with you that our training was very well attended last week with over 1,900 participants from over 140 countries and territories around the world. We also have made the recordings of the training sessions, as well as sharing the PowerPoint presentations of our speakers is available at the learning platform that you are signing on to, and also the UNDRR website at the QR code at the URL that we are showing on the screen. For this week is the second sessions of the training, and we will be focusing on introducing to you the tool called Public Health System Resilience Scorecard Addendum, how it can help strengthen the stakeholders' engagement and integrating the public health and disaster risk reduction planning. We'll have with us 5 speakers that will be sharing with you different perspectives around this tool, from the theory, what the tool is about, and also to the application by many different stakeholders. And I also would like to remind all of our speakers to kindly speak slowly and clearly, as we have relay interpretation services happening in 6 languages. And also for the participants to be patient for the interpretations to be completed. For this training course, we will keep the video and microphone of the participants disabled, but we will be keeping the chat box open for you to be able to interact among each other. As we have a lot of people joining the training, and currently almost 1,000 people also joining, we would like to kindly ask you to respect each other and kindly use the chat box in a respectful space, and refrain from posting a lot of the self-promotional materials or any discriminatory messages, please. We do encourage you to ask us a lot of questions though, and last week we did receive hundreds of questions, and we were able to answer majority of them by using the Q&A box at the bottom of your screen. So drop your questions in this Q&A box, and we'll be trying our best to answer them as much as possible through the Q&A box and also in the live sessions. So without further ado, I would like to introduce you to our first speaker, Mr. Sanjaya Bhatia. He will be introducing to us about the Public Health System Resilience Scorecard. Sanjaya Bhatia is the head of office for UN Office for Disaster Risk Reduction Global Education and Training Institute. He has been involved in a lot of training programs and has trained over 10,000 people in different topics globally. He also has been instrumental in development and application of many versions of the scorecard, including this public health system resilience that we will be talking about today. So without further ado, let me pass the floor over to Sanjaya for his presentation. Over to you, Sanjaya.
Thank you, Mai, and welcome to all the participants and also to all our speakers today. We're looking forward to a very exciting session. So I'm just going to make the kind of the foundational presentation just to put everyone on the same page. So not going to take too much of your time, but as you all know, you already know about the disaster resilience scorecard for cities. So one of the annexes is known as the Public Health System Resilience Addendum, and that is available. That's what we're going to talk about today. Not only about the what it's about, but also look at some real life examples on how it has been applied. So just to recap from prior session is that we look at resilience as a long-term process. And as you can see in the purple diagram here, there are activities which could take decades. There are activities which can take days. So we have to understand that it's an investment in the future, but it's a long-term investment. Secondly, we always talk about system of systems. So everything is interconnected. And as we, I think, mentioned even last time, that COVID was one of the examples of how something that initially impacted the health sector went on to impact even the price of oil and the aviation industry and tourism industry and housing shortage and whatnot. So all kinds of other sectors were impacted. Tax revenues reduced by about 25% for local governments. So we need to understand that something in one system will impact the others. Something in the health system will definitely impact other systems or other sectors, and that's why we are all in it together. We cannot say that this is something somebody else is supposed to deal with. And lastly, just for the recap, that we also consider the chronic stresses, which is criteria like poverty, access to education, access to health services, access to clean drinking water. All of these are magnified by disasters and then increase the vulnerability of the communities. So the approach of using the scorecard is again, just to recap, the scorecard breaks down the meaning of resilience, and it looks at 10 essentials, which we could almost call 10 sectors or 10 areas of work of a typical local government or even of a national government, actually. So what the scorecard does is it has those questions which help you to understand what is meant by the term resilience. What is the broad spectrum? What is the entire spectrum of resilience? And as you go through the questions in the scorecard, you are able to understand where you are, where you need to go, and in that way identify the gaps. So once you have the gaps, then you are able to develop a strategy with actions that you want to take to address those gaps, and then of course implement it. So the scorecard helps in the diagnostics part. helping to unpack the full meaning of resilience, helping to identify the gaps, and then helping you to formulate a strategy with an action plan. And this is just to show the 10, as I mentioned, the 10, we call it 10 essentials. You can even call it 10 sectors or 10 areas of focus. Right from number 1, which is organizing for resilience, meaning the governance issues. So do you have a committee or how do you coordinate this work? 2, looking at identifying risk. So the risk information. 3 is the finance. 4 is the urban development and design, and then so on all the way to 10, which is about responding post-response recovery. So building back better after a disaster, trying to understand what worked, what didn't work, and building back. The scorecard has 2 formats. One is the preliminary assessment and the other is the detail. So the preliminary has scores from 0 to 3 and the detailed has 0 to 5. And these scorecards were developed in a collaboration with IBM and ACOM and many other experts from around the world. And the scorecard was developed again similar partnership, including with World Health Organization, and we have Ben here as a speaker, and he is one of the authors of the scorecard. So it is all these scorecards, and there are more. They are all available at mcr2030.undrr.org. They are available in many languages. So please have a look, because there might be something of use for you, and you can download it. It's freely available. So the health scorecard is built on the same format. So it is available as a PDF and as an Excel. The other scorecard, the main scorecard, is also available as an online tool. But the health scorecard, you can download and then use it as an Excel sheet. And as you go along, you fill in, you answer the questions, you do your scoring, you fill in the actions that you need to take in case you determine that there is a gap. And in that way, you formulate your action plan and strategy. The scorecard is fully complementary with WHO's health EDRM, the Emergency and Disaster Risk Management Framework, and of course, fully compliant with the Sendai framework. I think I should also mention that the scorecard also, apart from giving you a draft action plan, it also helps you to visually analyze. So you see the spider diagram, spider web diagram that shows clearly where you are strong and where you are weak. The gray is what you can achieve, and the purple is what that city has achieved. So you can see, for example, essential 1 is weak, essential 3 is weak, and so on. So, so it gives powerful visual tools which you can use for advocacy, for fundraising, for convincing your bosses, but it also gives you the draft action plan, which is kind of the first step in trying to raise funds for these actions. So what does the public health scorecard cover? Well, it covers almost everything. And you can see in this list, it moves from hospitals, isolation facilities, nursing homes, emergency management systems, mental health, public sector health, pharmaceutical distribution, food distribution, water supply, staff and their skills, telemedicine, and so on. So it connects all of this, and that's why we call all of these tools multi-stakeholder engagement tools, because they make you think about the other stakeholders who should be at the table or in the room when you are discussing. And we look at the real life examples where this has been implemented. Again, looking at the breakdown, so some examples along the 10 essentials. So you can, I won't go through each and every line. You can have a look at these slides. They will be in the platform. But as you can see, again, it's breaking it down into the 10 areas or 10 areas of focus. And it has a number of questions. These are just some of those questions which are shown here. It also covers pandemics. And in fact, though it was developed in 2018, it became very popular during the pandemic, where many, not only cities, but also national governments used it to develop a plan to strengthen their systems and delivery. So it is free. It is available in a large number of languages. So again, go to ncr2030.undrr.org and see what languages there are, and probably the language that you need. It is there. So please download it. It will be helpful during this session also. And with this, I'll end, because I know we have these excellent practitioners who are to speak, and we all of us want to hear from them. So these are some of the key resources. Again, this will be in your material in the platform. So have a look at that also. And with that, I hand over back to Mike. Thank you.
Thank you so much, Sanjaya, for a very brief overview of the tool itself. I think it's it's a good foundation now before going to the next speakers. Although I have one question to ask you right now from the participants also. There was a comment around like the experience around COVID, and now that we are entering post-COVID era, there must be a lot of learning and experience that we can extract from. I wonder if you have any comments around how we can use this tool, the Public Health System Resilience Scorecard, to help to extract and find a lesson learned from the COVID situation.
Yeah, it's a very important point, and actually it's all covered in Essential 10, where it talks about building back better. And building back better means first dissecting what has happened. So trying to understand what happened, what worked, what didn't work, why it didn't work, and taking informed decisions and making a plan for building back, or let's say a plan for recovery based on those lessons learned. So there are a lot of documents, publications available from WHO, from UNDRR on lessons learned, and from many other organizations on lessons learned from the COVID scenario. So, but every local government, every government should do its own, because the context will differ, and make sure that the recovery plan is informed by these lessons. Otherwise, we are destined to repeat the mistakes of the past. Thank you. Over.
And are there any indicators within this scorecard addendum related to the pandemic, or anything that the city can use to help enhance and protect themselves from the future pandemic?
There are many indicators related to pandemic also. And for example, there are indicators looking at surge capacity for health facilities, surge capacity for staff. And all of you remember the beginning stages of the pandemic, there were shortages of supplies. So this one looks at also supply chains and increase surge capacity of supplies. So you remember there was shortage of masks, there was shortage of beds, there was shortage of ICU equipment. So there was shortage of PPE. So all those kind of questions are asked in the scorecard. And also the scorecard asks questions about skill development. So for example, even not only was there shortage of health personnel, but there was also shortage of certain skills. So again, going through the scorecard will definitely help you prepare, strengthen your health system, but also prepare for any future eventualities.
Thank you so much, Sanjaya. We'll keep more questions at the end of the sessions. Now, let me also take the opportunity to introduce the next speakers, Benjamin Ryan and Mayumi Kako. Benjamin Ryan, he is a clinical associate professor at Baylor University, Texas, USA, and he actually obtained his PhD in public health and has a vast experience working, researching, teaching in disaster risk reduction, environmental public health, and community resilience in many regions across the world, especially in the Americas, Europe, and Indo-Pacific. He actually has led a lot of the multinational research projects and conduct public health assessment in cities and rural settings, and as well as the use of public health scorecard in many of the cities around the world. He'll be joined by Mayumi Kako. Mayumi also obtained her, actually from undergrad to her PhD in nursing at Flinders University in Australia. And she is currently an associate professor at Hiroshima University, Graduate School of Biomedical and Health Sciences. She is from Kobe, Japan, where she also had experienced the earthquake that happened in Kobe. So she had developed the interest around disaster nursing and health, and has built a lot of professions, work in many institutions, including also the World Health Organization Kobe Center, and also practicing her nursing with the community voluntary services. So Ben and Mayumi will be sharing with us the experience in applying the public health scorecard resilience addendum in the global project. And let's give them the warm welcome, and the floor is yours now, Ben.
Thank you, Mai and Sanjay, for that presentation. Wonderful to be here with you all. Mayumi and I will go through this presentation. At the end, we'll also answer, she'll also provide an overview of her experience from a Japanese perspective as well with translation. So what we did is Mayumi and I were funded by the World Health Organization through the Kobe Center to roll out the public health scorecard. And this was across, in the end, 8 different countries. And I'll go through that in a moment. And we've got 2 of the presenters here today who are going to share their experience of implementing this scorecard locally as well. But I'd need to acknowledge the World Health Organization, the Kobe Center, for funding this project. Also Mayumi for being the co-PI on this project. Ryoma, Maki, Sanjaya, and Drina Capello from UNDRR Americas and the Caribbean. As you could see, this is a very large project team. This is something the public health system scorecard can lend itself to. You can apply this at the local level, so within your community or village, then scale it up to your province, and then go to a national level, and even go to an international level. And that's what we did in this effort here, and I'll describe what we did. So our aim of this project to identify the factors that affect public health system resilience, clarify and rank and prioritize actions. So we use the scorecard in local workshops to clarify, rank and prioritize actions for strengthening health system resilience based on the lessons learned from COVID and other disasters. We also had a focus on urban and rural areas. I'll talk a little bit about the work we did here in Texas in the United States. We applied this in a more rural area, as well as Dallas, Fort Worth area, which is very urban, a large city area in the United States. It also covers a whole of society approach. So that answers some of the questions around public health system resilience for COVID and the lessons learned. The beauty of this approach is it's focusing on the whole of society impacts. If you think of the emergency department physician on the front line treating a patient, that person's reliant on food, water, logistics, supply chains, all the aspects around them to provide that care. So this scorecard can help you systematically clarify and identify what those priorities are, so you can actually maximize the health services people receive. And the goal here is to come up with actions to reduce risks of future emergencies. Sanjaya covered a lot of this, but I just wanted to highlight these are the areas we need to focus in on, the second and third order effects or relationships with the health system around. We need energy, telecommunications, water, sanitation, supply chain. All these areas are what are vital for public health systems. They are dependent to function. So your workforce cannot be working in the public health system without these. And then the systems that can be impacted by the public health system are retail, public transport, social systems, public safety, business, and food supply. So you can see this is what we mean by systems of systems thinking when it comes to public health. Often the solution is not the first issue, it's second or third order effect. And you'll see some of that come from these recommendations from this project. I'll skip over this because Sanjaya spoke about how this links in with the Disaster Resilience Scorecard. These are some of the links to the WHO framework. So it links in with policies, strategies, human resources, finances. So you can see how these all cut across each other and work together to really come up with a systematic process for strengthening health system resilience. How we did this project, and this would be replicatable and scalable in most parts of the world. So we had strategies from 13 workshops in 8 countries and 284 participants. In all these workshops, the public health system scorecard was applied, the same methodology of delivery was applied, and then there was ranking and prioritization of recommendations or actions, usually around 4 to 5. These were then compiled into 70 recommendations, which we had everybody who facilitated the local workshops, all 13 local workshops, came to Incheon in March this year, and we spoke about our experience in implementing the scorecard, the recommendations, and then we had a modified Delphi process where we went through a survey, where we went through all 70 questions. This was done on day 1 in the afternoon after everybody presented on their presentations and their recommendations. We analysed the data overnight, came back on day 2 and had a consensus-based approach where we spoke about the results and what we should include or exclude for the second survey. That second survey was then done on the afternoon of day 2, and then on the morning of day 3, we came back and we spoke about the findings, and as a group came up with 23 prioritised recommendations from the 13 workshops in 8 different countries. We're now in the process of analysing this and distributing the findings. These were the workshop locations. So you can see here we've got developed and developing countries represented. We've got urban and rural areas represented as well. So you can see Chile with the first workshop. Then we had a workshop here in Waco in Texas. And then you can see this all going through. You can see Istanbul in Turkey, in Brazil, 3 workshops in Brazil, Slovenia conducted a workshop, and there's a workshop in Dallas, Texas as well. This is an example of what the workshops look like. Here in the United States, we had Nahul Arañez Garcia. He came and helped open the workshop at Dallas. He's the, at the time, the Deputy Chief of the UNDRR Office for the Americas and Caribbean. So I'd highly recommend you engage with Sanjaya and the team to help get this organised and facilitated. This here is the Dallas workshop participants. This is a workshop in Turkey as well. Professor Ismail was one of the leaders there, and we're working with him with follow-on projects, hopefully to help guide recovery activities and actions. So we think there's also potential there for this scorecard to help in recovery as well. And you can see in some areas in Turkey what they did, depending on group size, you have individual work groups and you'll report out your joint scoring, sometimes for indicators. Our focus was really individual scoring and then collating those and coming up with the data analysis from there. So we presented the 70 recommendations, and both Lucinda and Jeremy, who will be speaking shortly, will talk about their experiences in their countries. So survey 1, when we had our joint workshop, is we went through a survey, and this is where we followed the Delphi process. So a proven methodology, a consensus-based methodology to come up with commonalities based on practitioner perspectives. So remember, this process is practitioner heavy. practitioner focus, and working in academia, our role is to help validate this process for practitioners because it's being used in the field. And that's how we can make a real difference, is supporting those in the field. So a strategy was removed if 26% or more of participants recommend this occur. So we had a threshold, and this is the data analysis group we had. This is Shelby Garner, a professor from Belmont University in Nashville, and these were two of my graduate students from Baylor University as well. And then survey 2. So this is where we flip the methodology, and that rather than ranking what we want to keep or remove, in survey 2, we have by this time worked out what we think are priorities and should be considered as being high, very high, low, or very low, or average in significance in improving health systems. What we did here was a multinational approach, multidisciplinary. We had clinicians, so we had people who worked the front line in COVID. At this workshop, we also had people who were supply chain managers, logistics, emergency managers, academics. It was a multidisciplinary group we had here because we need that multidisciplinary approach to reflect all of society. Because if we focus on one profession by itself, we'll end up with bias. So that's how we aim to mitigate the bias here. You can see here the group as well. We also had computer scientists in the room. You can see here on the bottom left, this was the director of public health for Waco Health District here in Central Texas. This is Dr. Rob Fink. He's from Slovenia at the National University. He facilitated the workshops in Slovenia, and he's an environmental health science professor. So you can see the multidisciplinary nature of this group. These were the key strategies from the workshop. So you could see here, mental health came up. The order of 1, 2, this 3, 4, this is no ranking order. This is just how they were stacked in the survey. So we just put this in order for here, and as we do our analysis, we'll start to rank and prioritize. You can see here mental health needs, sudden influx of patients is a big issue. And these are the types of things the scorecard are designed to draw out from local community members, leaders, experts, and practitioners. How to engage communities. So here in Central Texas, the approach would be different to what you do in some parts of the United States and other parts of the world as well. Public and private health systems. The public system needs the private health system to help out because you've got medicines, medical supplies. A lot of the equipment that are run at public hospitals is provided by private companies. So you need a private-public partnership. And we saw that with the vaccine ramp up and scale. It was private sector companies that ramped up to develop the vaccine, and often it was public entities and hospitals that distributed the vaccine. So we cannot have health system resilience without engaging the private sector. Risk parameters, so understand what they are, at-risk populations. This was an interesting one, is disaster support services. So who can we draw on that are non-traditional frontline health service providers to support nursing homes, disability care centres, community centres and schools? Do we have local health plans? So you can see here some common themes, but they're all multidisciplinary. Alternative care delivery strategies. Can we use telehealth services, for example, to mitigate the impact of a surge of patients on an emergency department? And this is an interesting one that has also come up, was mapping interconnectedness of all aspects of the public health system, along with mental health workforce, and then ecosystem needs. So we really need to understand these needs. This was a priority from the Dallas workshop in Texas and also the workshops in Turkey, ecosystem needs and their impact on resilience. So what about water, water quality, air quality, all these things? How do they influence public health system resilience as well? And then also including funding in the public health budget. And going back to ecosystem needs, it also was a common theme with the need to invest in the social determinants of health to improve the overall health and well-being of communities, which in effect makes you more resilient to a pandemic or any emerging disease or virus. Here are some preliminary priority actions we've identified. Is really starting to understand the interconnectedness of critical health facilities and assets. Remember back to the early stages of my session where I said We need to focus in on those second or third order impacts because they influence whether we can have that workforce on the front line. Working towards a sudden influx of patients, scale deployable services for multidisciplinary health system services, linking high-risk populations with for people at home with pre-existing conditions, mapping the public health network, and a key aspect is also strengthening trust. So is that trust with faith-based organisations? Is it with sporting organisations or identities, celebrities? Is it government? It differs in different countries. So really working out that key avenue for strengthening trust amongst communities so they'll take up public health information. Our next steps is Mayumi and I are working to develop action plans. We're going to explore alignment with the WHO Health EDRM, and we're looking to create a pipeline from application of the scorecard into practice. And that's something that we'll be working with Sanjaya and Mai to really roll out probably now in September, not later this month, in September, to work out how can we create that pipeline to move things into action. At this point, I'll hand the Zoom floor to Mayumi for you to share your experiences in translation and perhaps the workshops you coordinated in Bangladesh and also Turkey. Over to you.
Okay, thank you so much, Ben, and also thank you for this opportunity, Sanjaya and Mai. I'm really grateful to be here. So I'd like to share the experience from Japan side. So we translated the scorecard with my team. So it was quite the long way because some word is it's pretty much different. I guess because everyone has their own different way to express disaster risk reduction and some different terminology, even within the English term, we always that the definition differences and we discuss about it. So, but I think I find it quite a good experience because when we really talk about what does this mean, not only within our own language, but also within the scorecard. I think some sentences, essentials is really you have to talk in a different perspective, which means from different department, who are stakeholders for the disaster reduction, and you realize when you talk with different department personnel, so we don't see their perspective. So when we talk about it, we realize for the health or maybe even the different area of the as Ben mentioned, some ecosystem, water system personnel talk about the health. So you're always finding out how everything elements of community to protect promote health is interconnected or impact each other. So in a way, the translating, it's good to have some different views to review, so that you might hear that what does this mean. So somewhat you have to keep neutral, I guess, that the wording to make everyone can understand. And then based on that, when you're having a workshop, I think it's a great idea to have a different perspective to promote communication as well as understanding from the different perspective. And then I think that's ultimately can, promote the communication from a different silo of where you are. And I think that's a really great idea. That I think that's what this is aiming for. So that's all what I'd like to mention from based on my experience. And then thank you. Thank you. Over to you, Mai.
Thank you so much, Ben and Mayumi. It's extremely interesting project that you have been doing, because I think it helps us see how the tools can help create global collaboration, global North, global South, not only with the public health practitioners, but engagement with academia, with your students, youth in the program, and highlight really the role of the the city stakeholders in the process of supporting the government in identifying the key strategies moving forward. There are quite a few questions I would like to bring out and ask both of you now. There's one question specifically to Ben's presentation around why do you choose the threshold of 26% to remove the strategies? Is there any kind of literature behind it, or what was the consensus behind like using these methodologies for deciding the recommendations?
Yeah, thank you, Mai. Great question. It's part of the Delphi process, which is published. I've had some peer-reviewed articles using this methodology, particularly applying it in Australia as well, with multidisciplinary government officials and community members in Australia. The threshold of 26%, the beauty of the modified Delphi process, or let's say the Delphi process in this scenario, is you need to adjust it to make sure you get an acceptable number, which is defined by the group, which is a consensus base. So 15% is often the common number. When we were going through the scoring, we adjusted that to 26%, and that's an acceptable approach because we engaged with everybody in the room to see if they were comfortable with that. So this is where it's consensus focused. And the idea here is a little bit different to when you go for statistical significance, in that we're focused in on what do practitioners have consensus on. Practitioners are the ones on the front line implementing things, hearing things from community members, and are that front line. So the Delphi process, it's also used by large multinational companies and private sector, very successful companies, to really make a difference to reflect community needs and consensus. So that's why we had that approach. And the reason why we have discussions afterwards is to allow everybody in the room to have the opportunity to pull apart each question if they wish. And there are opportunities to recall questions and bring them back up and reword them as well. So this is, again, a consensus-based approach. Often, if you've got 90% consensus might be the cutoff, because anything over 10% in a room is enough to say, look, we've got something here we need to include. So it's a little bit finite, and you need to be flexible and adjust worthy. But again, this is a process focused on practitioner needs, experiences, and what they believe can actually be translated into action to make a difference.
Yeah, that makes sense. And maybe one question to Mayumi, from your experience also in applying this in Japan and Bangladesh. There is basically the interest of using the tool. There are people who are now understanding the need to do public health and integrate it with disaster risk management and uplifting the city's strategies in better response and prepared for future scenarios. They just wonder, like, what would be your advice as the entry point of first steps if they want to actually do the same in their local context? Do you have any advice for them?
Yeah, I think that's it's a great question. You know that, for example, in Japanese context, I was wondering how we can approach to those you know, the stakeholders at the local government. So I think it's you know, somewhat, you know, if you want to implement, you have to kind of to be explained what the tool is, so that in a way, when you're having a workshop, I think, you know, ultimately you make you know, good you know, explanation who could be the participants. So you, first of all, you have to really understand what this tool means, and maybe in a way, maybe that who are thinking to implement, you could you know, with your colleague, or maybe your different local government, you know, that who are network. I think it's a good idea to get together, talk about it, and then some starting from the small groups, or you know, that some within the same department colleagues, and then how we can utilize, and then I think always there's some way to connect each other, so that you know, I think from now on, Jeremy and Luciana is going to present how she did it. So, and there are always some previous exemplar, so that I think it's a good way to see how you know, that implement, and then we really encourage you to explore a bit more. Yes.
Okay. So well, there are also good examples and cases. And perhaps like anyone interested also can reach out to both of you, Mayumi, Ben, and also the two speakers that will be speaking next. Right. So thank you so much, Ben and Mayumi. Just there are also some questions in the Q&A box that would need your expertise in responding. So if you can stop by and check and respond to some of the questions, that would be very helpful. Thank you, Ben and Mayumi, once again. Next, I would also like to introduce you to the third speaker of today, Luciana Peters. Luciana, she's currently Deputy Director of the Secretariat for Innovation and Science and Technology at the state of Rio Grande do Sul, Brazil. And she had obtained education in international relations, international law, high politics, and has been engaged so much in international cooperation. Former to this position, she served as Manager of International Relations and also the Resilience Coordinator of the Municipality of Porto Alegre in Brazil. That's the place where she actually was spearheading the adoption of this public health scorecard addendum to support the cities and defining many gaps area and proceed in identifying the recommendation for improvement. So I would like to now pass the floor to you, Luciana. The floor is yours.
Okay, can you hear me, May?
Yes,
Okay.
very clearly.
It's good. It's a pleasure to have received the invitation for UNDRR to speak in this training. I take this opportunity to greet the organizers, the UNDRR Global Education and Training Institute, as well as the speakers and partners of the workshop that took place in South Korea in March. Sanjaya, Bhatia, Benjamin Ryan, Mayumi, Kako, Jeremy, Novak, and all the coordinators in the figure of Mutarika. It's pleasure. I can, my experience as a specialist in urban resilience began when Porto Alegre was selected to be part of the Rockefeller Foundation 100 Resilient Cities project, which resulted in the formation of a working group on resilience in Porto Alegre. In 2040, the working group concluded a text filed in 2015, bill the city council and sanctioned in 2019 to establish the Cesar Busato Municipal Resilience Plan. In 2016, Porto Alegre creates the Resilience Coordination responsible for executing a resilience strategy elaborated in the same year, the first in a city in America Latina. Since 2021, the capital has been part of the global network of resilient cities, which integrates the regional coordinate committee for MCR 2030 in the Americas and Caribbean. It was through this partnership between UNDRR and the Global Network of Resilient Cities that in 2022, Porto Alegre joined the initiative. The municipality has entered step C on the MCR 2023 roadmap directly, with the aim of accelerating the review of the resilience strategy and strengthening its metroplan risk governance through its candidacy for the MCR 2030 Resilience Hub title. Specifically, my experience in using the public health scorecard addendum was when I worked at the municipality of Porto Alegre, and is it was on
Luciana, I think we are losing your connection. Hi, Luciana. Can you hear us? Okay, if not, then maybe we have a change of the sequence for now. That we apologize for the technical difficulty. And Jeremy Novak, would it be possible that we switch you as the next speaker first?
Yeah, that's fine.
Yes,
not a
fine.
problem.
So thanks. So we'll come back to Luciana when she can reconnect with the internet. And so for now, let me move onwards to Professor Jeremy Novak, who will be joining us also in presenting his experience in applying the public health scorecard in Australia. And Professor Jeremy Novak is Pro Vice Chancellor and President at Global Development College. And he has expertise in strategic development, crisis and disaster risk leadership and management, resilience and adaptation, and had a vast consultancy and advisory experience with many of the sectors working on development and beyond. Professor Novak also has been behind supporting also the development of many of the scorecard addendums, and have been having first-hand experience in applying the public health scorecard addendum. And it's also a pleasure to also share with you that actually Jeremy joined us at the first training of this very program that we delivered by UNDRR, UNOSSC, WHO, and PAHO back in 2020. And I believe that was the first time he actually encountered about this public health scorecard addendum. And now a few years has passed, you have the experience in applying it, and we are very welcoming to you to join the training again and now share the experience of how you have applied the tool. So over to you, Jeremy.
Okay, thank you very much, Maya, and good morning, good afternoon, and good evening to everybody throughout the world. Okay, so what I'd like to talk today about is a particular the implementation of the scorecard in Australia. We did a number of things, and we'll go through those, but the particular one we want to focus on here is the Darling Downs Health District area. Now, with this one, we also conducted one over in Pokhara in Nepal, which was a very similar population size as what Toowoomba is. However, geographically, it was a lot smaller. But today I'm just concentrating on the workshop that we held in the Darling Downs. Okay, so what we wanted to do is to acknowledge Professor Ben Ryan. He made his way over from the United States to do the workshop and facilitate it with us, and Miss Kenzie McLeod, she was a real big help as well, organising everything and facilitating as well, so we couldn't have done it with that. We also would like to acknowledge the World Health Organisation, the Office of Disaster Risk Reduction, okay, for facilitating the scorecard, Darling Downs Health District, Toowoomba, Global Development College, who would put a lot of funds into it. Professor Ben Ryan, again, Sanjaya, Bhatia for his help. Kenzie McLeod, Robin Moore from the Northern Territory PHN, Grande Case, who is one of the directors of the Darling Down Health District, and Denise Bellinger, who was one of the assistants there as well. All right, so today what we're going to go through is some fun but useful useless information, I should say. Okay, the Darling Downs District and Toowoomba workshop demographics, and finally we're going to look at the workshop results. Okay, so starting off, just to contextualize the geographical location and also the population, a question for you. So which is bigger, the Republic of Korea or Australia? Well, South Korea's population is nearly not quite double what it is in Australia. So huge population in South Korea, we're about half. However, when it comes to how many times Republic of Korea can fit into Australia, you'll be astonished to know that it is about 78 times bigger. So South Korea is really small in geographical location, but double the population, yet we're 78 times bigger. Now, what's that got to do with anything? Well, if you have a look over here on the left-hand side, the one in green, that's the Republic of Korea. The Darling Downs district is approximately, and this is Queensland where I am, this is the state of Australia. This is the size of the Darling Downs Health District. It is actually bigger than South Korea. So that poses a lot of problems geographically. However, the population is a lot smaller. So that's some challenges for governments as well. Okay, so the demographics of the workshop. We had 3 disaster management experts in there, emergency services in there. That was 6. Now, the emergency services and disaster management were very much interchanged with the local disaster management group, which is headed by the local council and the mayor of that council. So they were very proactive. We had a couple of environmental scientists, principal public health officer, registered nurses. We had from the hospital itself, and they were involved with ED and also the COVID response team. So they were very, very well versed in it. We had the assistant director of nursing there. We had the director of pharmacy and a pharmacist as well, who was involved with the COVID response team. So these people were very frontline people, very expert. They were experts in their area. So we got a lot of rich information, rich data from them, which was very, very encouraging. All right, so going forward now, Sanjaya presented this spider web or radar, depending on who you talk to, the score. The overall score that the workshop received was 61 out of 115. And as you can see there, all areas were not up to best practice, or there was a lot of areas that could be improved. And this was, as Professor Ben Ryan said, yeah, this was practitioner led, not academic led. So this was their results that they came up with. And on the day, there was a lot of discussion and debate about each one of the 10 essentials and the 23 odd questions that were there. Okay, so here we go. This was the average score that we got from each one of the 10 essentials. And as you can see here, A2.3, inclusion in disaster planning, pre-existing chronic health conditions, including non-communicable diseases, scored very low at 2. And you can see the scores were hovering around that 2.5 to 3 mark. Okay, so from A7 right through to A10.2, you can see there the A7.1, effectiveness of public health system and community engagement in the context of disaster risk management, was a very low score. Perhaps the lowest of them all, and it was the lowest, was the community's ability to return to normality from a mental health perspective. This was a really big one, and there was a lot of lockdowns in Australia. The lockdowns were, you could not go from one region to another. There was a lot of issues with not seeing family members, elderly people in nursing homes. There was a lot of lockdowns that caused a lot of mental health issues, and that was a big thing as well. Okay, 9.3 also received a 2, and a 10.1 were mitigating the long-term impacts of public health well-being again. So well-being, mental health, they were some really key findings that came out of this. Okay, so low score, again, just to reiterate, 7.2. And I really encourage every participant to go onto the UN website and download this health amendment, you'll have access to these particular slides, and you can drill down and say, right, this is what this one means. Again, 7.2, 2.3, 7.1, 9.3, and also 10.1 were the lowest scoring ones there. Okay, so recommendations. There were 4 major recommendations, and we're going to look at some other ones on the next slide. So explore lessons identified during COVID-19 in mass gathering, and I might go over to the next slide shortly. Identify strategies to stand up general practitioners when hospitals surge. Explore alternative care delivery strategies, increase surge capacity. This could include activating telehealth. For those who don't know what telehealth is, I'm sure most of you will. It is the ability for a general practitioner to contact a patient online, or to do a video conference like this, or they can physically call them on the phone. Okay, for increased awareness and knowledge of the ecosystem in urban and rural areas, and the role it has on supporting public health. So that ecosystem that Ben spoke about previously, that also was raised in the workshop on the in Toowoomba on the Darling Downs. All right, so let's have a look from this perspective. Okay, the grid that we utilized was, the difficulty and or cost to implementing these recommendations through the impact and benefit. Okay, so maybe funds available. So what we had here was that this one here came up first, was increased awareness on the ecosystem, risk in the urban rural areas. The next one came up was explore alternative care delivery strategies for surge capacity, including the telehealth, again, under the Queensland Disaster Management Association. Okay, identify strategies to stand up GPs when hospital surge in the Darling Downs was occurring. And that was a really big thing. There was a little bit of a discourse from the participants that were saying that the standing up, the leaning forward, standing up, and leaning back from when the surge capacity wasn't as good as what they thought it was. And this was something that could be considered a low-hanging fruit and a really good thing to do. Okay, the low-hanging fruit and something that had really big impact and low cost was exploring lessons identified during COVID-19 and mass gathering incidents to assist in the surge capacity. Now, after they reduced the lockdowns in Australia, there were certain areas that had mass gatherings, and this ended up having COVID-19 get higher in those particular areas. So that was one of those things that was seen as a low-hanging fruit and what have you. All right, so if we go on to some observations and next steps going forward. Okay, one of the big things was people with disabilities, the inclusion. Now, the observation that the people in the group made, and also we made, was that people on all spectrums must be supported to move actively, more actively, as they were seen as the hidden population. It was a really big thing in the district. This was also noted in Pokhara in Nepal as well. There was a need to develop better support services for the vulnerable groups and their fundamental rights and what have you. And these hidden people were people that were actually locked in their houses for days, sometimes weeks on end. Okay, the next observation was that the comprehensive mitigation and post-event public health plans had not been developed or implemented in its entirety. This was a real shock to a lot of us that were there. And when we pulled it further apart, when I've had dealings with the Darling Downs Health District, they've also may strengthen a lot of these mitigation strategies within inside the hospital sector, because they realized that after this event, this informed the directors of the hospital, and we've been working with them to increase those areas. And finally, this is a really, I've touched on it a number of times. Okay, there were four physical and 3 online workshops organized. Okay, however, one could only be completed. Now, the 4 physical ones, we actually were going to do them in Townsville and also in Darwin. We had them organized. The Darwin, the night before the Darwin event was to happen, the government called a lockdown, and because the COVID-19 cases had gone through the roof, and 2 days before the Townsville event, same thing happened, and the Queensland government shut down all the area in Townsville. Okay, so there was that recurring lockdown that was coming through. There was limited movement and gatherings available. So as soon as they said, look, we're not going to have any more than 5 people in the room, due to the efficacy, the validity and reliability of the study, we needed a minimum of 12 to 16 people in the room. So that was it is. Now, the major theme that came out of this was that the public health, medical, allied health and related supported workers, out of all this, and when we asked people, you know, how come you didn't come, or how come you're not interested, or what have you, it came out that they were COVID response fatigued. There was that many lockdowns. It was just COVID. So there was that underlining the people that were involved in the frontline COVID response. They were fatigued from it, and to even get the information out of them is really challenging. So those are some of the results and some of the observations. Okay, so the next step, we need to conduct research in lessons learned identified during COVID-19 and mass gathering incidences. And the other thing is that we need to conduct further research and practitioner-led research into this as well, to identify strategies and best practice to stand up those general practitioners in the hospital and surge areas. Now, the other one that could be argued is how we can target and don't leave anybody behind with our most vulnerable members of our communities, people with disabilities and what have you. So that's a really important thing. Okay, ladies and gentlemen, that is all that I have to add to today. I hope you have enjoyed this little bit of information I was able to give, and I look forward to anybody's questions. Thank you.
Thank you so much, Jeremy, for this comprehensive example that you have been working with within Australia. And just maybe a quick questions around from your direct experience, because you're actually not the expert in public health issues, but you're the one actually applying the tools to support in increasing the health resilience issue for the city. From your experience, like what has been your experience around that, and what do you see your role as even the non-health practitioners to be partaking in this process?
Yeah, thank you very much for that question, Maya. Look, I have a medical background. I was a biomedical engineer for many years and what have you. So I was not in the allied health area, and so even though I was worked in the medical field, I was not on the front line of the COVID-19. But the experience that we found was that my PhD was very much in that crisis and disaster mitigation area, and this was how do we mitigate the impact of COVID-19, especially onto our most vulnerable people, and what have you. The workshop itself and the practitioner led, it was, and Ben was very heavily involved in this, it really brought out major themes and rich information that could added a lot of contextualization, especially for the rural areas where Darling Downs is. In rural areas, funding is a real issue. So how do you get the biggest bang for your buck, or biggest, how can you implement the low-hanging fruit that can make the biggest impact for the least amount of money. And that standing up GPs, getting those other areas that we talked about, that was a real key theme. And the identifying of that disaster management plans and resilience plans weren't developed enough, and they still weren't developed enough even after the COVID-19. They were the real things that practitioners came out and they went, wow, we just didn't realize it was getting those groups of people in the room, those practitioners, and getting them to identify, you know, by those groups of people, their minds coming together, they could see the holes in those particular areas.
And that's wonderful. So we, even the non-serious health practitioners, we can also actually adopt it and help to facilitate the process to create a dialogue with these different entities within the cities, and actually can eventually yield the recommendation that could be useful also for cities. And you spot on about the application of this in your case in the rural area. There also was questions around key recommendations if they actually want to apply this in the rural settings that has limited infrastructure, limited funding. What would be your recommendation for the entry points on this? Yeah,
look, even in the Darling Down district, you had Toowoomba, which is the biggest inland city in Australia, but it's still a big country town. Now, but outside of Toowoomba, when you travel 25 kilometres, you are talking about small villages, less than 1,000 people. And further west you go, like 400 kilometres, that's still in the Darling Downs area. So it's got to be contextualised for that particular local area. For example, if you are 50 kilometres or 100 kilometres away, what is that need in that particular geographical area with small amount of people? What can they do? And this is where the implementation of this scorecard in that area, where you've got the local volunteer fire brigade, the local volunteer ambulance group, the community group, the local mayor of that city area, how can they, what is the public health issues in that particular area? The local GP, the local nurse. There may not be a GP in that area, but there may be a community nurse or a couple of community nurses. This scorecard, the way I see it from a rural practitioner's perspective, allows you to take it and then to do that in that particular area and get the rich information out of that. And you can apply it or feed that back to the major city areas and say, look, this is what our people in this area need. That's what they've come up with.
Thank you so much, Jeremy. So we'll keep the rest of the questions for later. And thank you so much for your presentation. Now we also have Luciana back to our call now. So may I also re-invite Luciana for her continuation of the presentation. And Luciana, great to have you back online with us.
Hi, May.
Yes.
I am back. The internet in the building is down. Thank you very much for your attention.
Sure. So the floor is yours now for presentation.
It's okay now. I will introduce a little bit of Porto Alegre. Katrina, can you go to the next slide, please? Okay. Your city has an estimated population, more 1 million inhabitants. Porto Alegre is located in the south of Brazil. It is a heterogeneous city, which has a great characteristic. Is the second Brazilian capital with the largest rural area. Can you go to the next slide, Katrina, please? The next. Okay. Enacted a law number 12, creating the pesticide-free area in Porto Alegre. The farmers will have 14 years to adapt to the law. Therefore, we will have reduction of environmental pollution. We offer health food, strengthening family farming with economy gains for family farmers, and at the same time, contributing of the sustainable food and national nutritional security of entire population. By offering health food without contamination by pesticides and better biological quality. This is the current Municipal Secretary of Governance, Castro Gildo, instituted the resilience plan in Porto Alegre. The next slide, Catherine, please. This workshop was possible through MCR 2030 World Health Organization, UN Office for Disaster Risk Reduction, Baylor University, City Hall of Porto Alegre. The next slide, please, Katrina. The results of the scorecard. Total number of participants, 32 in workshop in Porto Alegre in November ago, 2022. This result by thematic, Porto Alegre obtains 49% of total possible score in the public health addendum. This percentage is explained by the very structure of the public health system in the face of risks, which was consolidated based on the lessons learning during the COVID-19 pandemic. Once again, the average score of the public health addendum in this group of principles is explained by the large number of projects to raise awareness and prevent biological risks, viral, bacterial, and zoonosis carried out by the health system. The next, Catherine, please. We reached on the first line, we reached a percentage of 50. We have a very robust organization and complete regulatory framework. The scorecard was useful the city for the moment it identified. The next, please. Strategic objectives, great integration of public power with civil society and the engagement and participation zone policy of resilience. In the recommendations, submit a contingency plan to population and sensitize the entities, private and public, in the mobilization of health service. The next, please. Next steps and observations. Porto Alegre has a well consolidated resilience agenda, but with a lack of integration with other sectors of municipal public actions that also impact risk management, capabilities, and build urban resilience. Number 2, resilience strategy update. We have already started the construction with the review of our first strategy and the intention to set up a resilience committee. Number 3, foster great synergy between sectors of the City Hall and actors in society. Number 4, risk-informed urban development. We have already started the process. In number 5, ecological transition. The next slide, Catherine, please. Thank you so much. It's very important for us. That's why UNDRR, and I think so. That's it. Thank you for opportunity. May, you have a question?
Thank you so much, Luciana. So it was a brief presentation, but basically captured the similar process of which Ben, Mayumi, and also Jeremy has been presenting, but from the perspective from the local government in Brazil. So it's very interesting to see the similar extractions of the recommendations, gap areas you have experiencing. Maybe I have a few follow-up questions to you, Luciana. From your experience when you were working with the municipality of Porto Alegre, how do you assess your experience in using the tool? But before you answer, let me also give a reminder to all the audience that Luciana will be responding to my questions in Portuguese language. And so please select the interpretation channel and select the English channel if you would like to hear the interpretation of the answer. So over to you, Luciana. Let me repeat the questions again.
Yes,
Please.
please.
When you're working with the municipality of Porto Alegre, and you apply this public health scorecard tool, what did you see as an experience when you actually introduced this tool and work with your municipality?
In Portuguese or English?
Any language. Portuguese is also fine, but for the audience,
okay.
you need to select the English channel to hear.
Okay. My experience with the Scorecard tool allowed me to see that local governments across the state can create conditions in order to disseminate and develop integrated disaster risk reductions management strategies, and that information about risk can be considered in the urban development of your cities by sensitizing local government agents to key issues on the international agenda for disaster risk reduction, increasing their technical capabilities using the tools for diagnosing resilience capacities and planning risk reduction actions offered by MCR 2030 and UNDRR will strengthen in this way its action and promoting risk reductions and urban resilience actions.
Okay, lovely. So the key 3 points you mentioned is that with your experience, it did help to enhance your urban development plan of the cities, and also help to connect with multi-agencies and for them to understand the international agenda on disaster risk reduction, and also an opportunity to increase the technical capacity. One more question for you. Now that you are no longer working with the municipality and you're moving an upper level to work with the state level, do you see any opportunities or potential benefit that the same tool can be applied or used with the multiple numbers of municipality within your state?
Okay, thanks, May. Great question. I see any potentials. Today, I am Deputy Director of Secretariat for Science and Technology Innovation of the state of Rio Grande do Sul, and I see enormous potentials and great benefit for articulation with the state government, especially through the existence of emphasis on health in the state government plan and the Secretariat for Science and Technology and Innovation, which is in its 20 2023 and 2026 strategic plan lists the state and innovate center in innovative center in health. In case there is interest, it's possible partnership with the state. If you are UNDRR, MCR are interested, we can schedule a meeting when you have available agenda.
So that sounds exciting. So we look forward to your new roles at the state government to see how you can actually replicate the same model to all other municipalities in your state. Wonderful. So with this, our presentation has ended, and I would like to thank all speakers, Sanjaya, Ben, Mayumi, Jeremy, and Luciana, also for sharing so many experience with us, and very practical experience, I would say. And from this, we can really see that this public health system resilience addendum is really a practical tool that helps to bridge and bring in different stakeholders together, and help to identify also how you can work together to enhance resilience building. And the tool is actually free of charge. You can freely use it. It's available in, I think now, almost 20 languages. And you can have the opportunity to use it to reevaluate the current plan, to design the new plan, and also create the multi-sectoral collaboration. And on top of that, identify a lot of the different roles that the whole of society can play. We have heard today the experience from not the UN agencies, but from academia, from health practitioner, non-health practitioner, from the cities in global south and global north, and the global collaboration that can bring like all of this exchange and experience together for learning purpose, and for how to make sure that we collaboratively help to create the resilience of the cities together. So if you're actually interested to learn more deep dive about this tool, there's actually a free online self-paced training course available on the UNDRR learning platform. And we'll be dropping the link to the chat that you can check out, and you can get the deeper dive into understanding this public health resilient scorecard addendum. So this also brings us towards the end of this session, and that also marks us halfway into this training of the 4 live sessions. Next week, the 3rd session will be led by our colleagues from WHO and PAHO. The main topic of the sessions will be around whole of society and urban health disaster risk management from theory to practice. It will be focusing on key frameworks, concepts, and tools on health emergency and disaster risk management in the urban context. The whole of society and whole of government approach to reduce risk and impacts of emergencies and disasters will also be discussed. The session will also address the role of youth in health emergencies, and particularly disability inclusion in disaster risk management. So a very exciting lineup of speakers coming up for the next sessions as well. Before we depart today, lastly, let me stress again on the course requirement. You must attend at least 3 live sessions, complete the end of the course survey, the feedback surveys that will be given to you at the end of the 4th session. You also need to pass the end of the course exam, which is multiple choices, and score above 80% in order to achieve your certificate of completion. All of the materials will then be downloaded on the learning platform and also the UNDRR website. Just look at the right-hand corner of the website where it says attachments. You just click drop down and you can download all of the PowerPoint from last session and also this session. The recording will also be uploaded on that platform, so you can review that before you take the end of the course test. So last minute here, I also would like to once again thank all of our speakers, Sanjaya, Ben, Mayumi, Jeremy, and Luciana, for joining us and share so rich experience together. I would also like to extend my thanks to the organizing teams working behind the scene that work very, very hard to put all of these sessions together on a weekly basis. Also extended appreciation to all the interpreters. We have all interpreters in 6 languages. We have massive pool of the team behind the scene as well. And lastly, to all of you as participants to the training course. Today, we also had at some point more than 1,400, 1,500 people joining us today. And thank you for spending time with us. And we look forward to see you again next week. Thank you so much and have a good night, good day, wherever you are.